3 phases. You must know all of them. Cardiac rehab is when someone enters into after an adverse cardiac event. So most commonly it's after a heart attack, but it could be any cardiac issue. Phase 1 is the acute phase in an inpatient setting. It usually lasts about 3 to 5 days, but pending medical stability. So once they're medically stable, that's when phase 1 begins. So we do not intervene and try to exercise the patients until they are considered medically stable, and the physician would then order physical therapy. Okay, if they then begin phase 1 and become medically unstable, that obviously would increase the length of time. But pending medical stability, it should only last 3 to 5 days. Okay, so after they are medically stable for 24 hours, the physician will order physical therapy and phase 1 will begin. They have to be medically stable for 24 hours. Okay, here's where we are going to introduce the concept of MET. Does anyone know what a MET is?
Like what the acronym is?
Yeah.
A baseball player. Baseball.
Metabolic equivalence. Okay, so we use oxygen for energy. So metabolic equivalence estimate how much oxygen is required for an activity. So it's another way of gauging the intensity of an activity. So very commonly during cardiac rehab, heart rate will not be a reliable source for exercise intensity. Why?
The heart's been compromised by an incident, so it's already gonna be working harder.
It may already be working harder, that's not actually most commonly why. They're gonna be on a whole bunch of drugs, and those drugs are gonna be abnormally changing the heart rate so the heart doesn't have to work as hard. So yeah, the heart's been compromised, so they're gonna be put on medications almost always to help decrease their heart rate so the heart does not have to work as hard. Therefore making heart rate an unreliable source to refer to for exercise intensity. So instead we have to use MET level of activities, and what else can we use with the patient? Rate of perceived exertion. Okay, and I'll go over what different activities are for what different activities are MET-wise. One MET is if our body is resting, like when we're sleeping, our body is using 1 MET. Okay, so baseline is always 1. Can't go below 1. So 2 to 3 METs is really hardly doing anything except really basic ADLs. 3 to 5 METs, which is the maximum you progress to in phase 1, is doing higher level ADLs, like walking to the bathroom. Versus 2 to 3 would be like brushing teeth, combing hair, rolling over a bed. On page page 246 in your PTA book, they have a chart of METs ranging from light, greater than 3, moderate, less than 3, moderate, which is 3 to 6, and vigorous, which is greater than 6. I also provided you in those supplemental PDF files called cardiovascular review or something. There's a better, more descriptive MET chart in those.
What page was that again?
246. So get to know what activities are what MET. Okay, so once again in phase 1, You start at 2 to 3 meds, because you're not starting at 1. 1 is rest. The maximum you progress to is 3 to 5 meds by discharge. During exercise, you will be using rate of perceived exertion with the patient, and the intensity should only ever be considered light. If you can use heart rate as a measure, you do not want it to go 10 to 20 beats above resting. So no matter what, whether they're on medication or not, whatever you do with them, their heart rate should not increase greater than 10 to 20 beats per minute above resting. You will not do any resisted upper extremity exercise during phase 1. This usually lasts 6 weeks, but again, they'll be in phase 2, middle of phase 2 by then. So during phase 1, there's absolutely no resisted upper extremity exercise. You can do passive and active range of motion, but you do not add resistance. So because we're staying at these low MET levels and we're still in the hospital, we're focusing on ADLs. And the other huge focus is patient education on self-monitoring. They've just had some sort of adverse cardiac event. They have to be aware of their activity restrictions and when to identify when their activity is becoming too intense for their heart to handle. What other sort of things besides self-monitoring of intensity are we going to educate the patient on? Lifestyle, good lifestyle changes for good cardiac health. These different phases actually are not reviewed in your PT exam book, but again, I gave you a chart in that PDF, one of those PDF files that goes through all of this. But I included everything you need to know on these slides. Okay, phase 2 is once they're discharged from the hospital is considered the subacute phase, and they will go to a very specific outpatient cardiac rehab center. Lots of hospitals have them. So phase 2 is 3 times a week for 12 weeks, and they will be there for 30 to 60 minutes, or be exercising for 30 to 60 minutes. So in phase 1, we discharge the patient at 3 to 5 mets, so that's where we're starting. The maximum level we progress to is 9 mets, which is pretty high level. Okay, so we're going to progress from just working on ADLs to working on more functional activities. So we want their ADLs to be unrestricted. So no angina, no limitations during their ADL. Then you will progress on working towards habitual and occupational activities. Okay, we're going to do a little bit more promotion of risk factor modification and lifestyle changes so that their heart can continue to get healthier and not get worse. Okay, resistive exercise, whether it's upper extremity or not, may begin after 3 weeks. So we have the 3 to 5 days of inpatient, and then 3 weeks into phase 2, we can begin strength training. But if they had an MI, we have to wait 5 weeks, and if they had a cabbage surgery, aka chest open, wait 8 weeks. Yes, including upper extremity. So all upper extremity, lower extremity. Okay, so that's why they say here the average is lifting is usually restricted for about 6 weeks, but it depends on what the adverse cardiac event was. So the earliest strength training can begin is 3 weeks into phase 2, but if they had an open chest surgery, you have to wait 8 weeks. And you're going to begin with very, very lightweight and progress only to moderate loads, not heavy loads. Okay, okay, what percent of max heart rate, if we can use heart rate, what percent of max heart rate are we beginning at? 40%. What are we progressing to? 60. Okay, so 3 to 5 METs or 40% heart rate max, progressing to 9 METs or 60% heart rate max. Normally, for a normal, healthy individual, what percent of max heart rate do they need to exercise in order for it to be considered aerobic? 70 to 90. But these patients, no. And definitely not in phase 2. Okay, so add that in about the percent heart rate. That's the only thing I didn't include here. 40 to 60%. Begin at 40, discharge at 60. And we're still teaching the patient how to self-monitor intensity of exercise. Okay, phase 3 is kind of, you can almost think of it as it's almost like an optional phase, or it's just what someone's considered in after they finish phase 2. And it's considered post-acute. So it's either a maintenance phase where you discharge the patient independent to their home exercise program, or maybe that patient is younger and formally performed at a higher activity level, or their job requires a higher activity level, then they'll receive more outpatient physical therapy. Okay, so you're promoting self-regulation of their own exercise program and a lifelong commitment to risk factor modification. And this is where you can progress to higher percentages of aerobic capacity. And MET level-wise, it would just be greater than 9. Okay, so again, not everyone gets actual physical therapy during this phase. It may just be you've discharged them to their home exercise program. That's considered phase 3. Actually, a lot of cardiac rehab facilities offer it's almost like a gym membership, where the patients can then pay out of pocket and still go and use all the cardiac machines, so they keep up the same routine that they got into when they were doing 3 times a week for 12 weeks. So I've treated lots of patients who've come to see me for physical therapy, and their recreational exercise is still going to the cardiac rehab center.
It's like a gym for sick people.
Yeah.
Amazing.
There's actually a very cool gym sponsored by the Goodwill in Santa Ana. That's a disability gym where all the equipment is wheelchair accessible.
Oh, that's cool.
Very cool. Okay, so know all the phases of cardiac rehab. Your next test will have lots of questions on it, and the board exam will have lots of questions on it. Question?
Will there be more specific parameters given by the cardiologist within as far as ATs or these percentages for the target heart rate, or we're just going to stick with those values?
You really stick with this, because otherwise it wouldn't be medically sensitive. And the physician is not the expert on it. They just make sure the heart is still pumping. Make sure. Okay, we're going to watch a little respiratory video brought to us by Jimmy.
Wait, is this one of his videos?
No, they haven't.
Jimmy is not in this video.
Not in the video.
No.
Thank God.
No.
Do you want to give a little intro as to what it is?
Yeah, so they used to do this stuff called cinefluorography before they realized that all the radiation was really bad for you. And this guy, Carl Stowe, back in the 60s and 70s basically developed a method of diaphragmatic breathing that he helped teach all these emphysema patients, which made it so that they could walk around much better. And a lot of it was just by kind of like touching their chests and getting the accessory muscles to relax.
And that's what we do.
Yeah.
Okay, so I kind of just glanced through and picked out some clips. There's some cool parts of the video where they like simulate the diaphragm moving, and then you'll actually see it like looks like a moving X-ray of different patients breathing.
Yeah, and the healthy diaphragm, you can tell it moves up and down, and in the really sick diaphragm, it does this like weird bubbly thing and contracts on one side but not the other. It's really
No, I have not listened to the narration, so I don't know what they're saying, but I know the video.
okay.
Of all of the groups of breathing muscles and the individual breathing muscles, including the diaphragm, the abdomen, and those around the neck and the throat, why the air can flow out of these areas which remain obstructed under every other circumstance. And we have shown that he is able to decrease the volume of the lungs more than any pulmonary man would say was possible. And the function of the diaphragm redeveloped. And Carl refers to this quite correctly as redevelopment or development of the diaphragm. Now, many studies that have been done in the last 5 years have been done at the wrong end of the spectrum. They've studied how forcibly the diaphragm can pull down an inspiration. That's not the important thing. The important thing is what Carl has shown, that the diaphragm can be gotten to relax and go up, to rise, so that during inspiration it can come down. It's got plenty of strength. You don't need to measure the strength.
I also learned about respiratory faults. Now, respiratory fault is an abnormality. I knew it as an abnormality because with the emphysema patients, all their chests were raised and tight, but there is a joint right in the sternum, the breastbone, at the second rib, and it's a cartilage joint and it's for flexibility. But if you use what is called accessory breathing, where you use the muscles of the upper chest and the shoulders and you grab for a breath, you pull on this joint and it lifts the chest on the inhale, and the diaphragm will tend to slip underneath it, and when the diaphragm tries to rise, it will hit the bottom of the rib cage and make the ribs flare. This is called a respiratory fault, and it was thought impossible to reverse it. Once you had it, that was it. Well, of course, that was true if you couldn't redevelop the diaphragm. But as I was able to redevelop the diaphragm started going up inside the rib cage started to release around it, and the joint in the sternum became more straight, and even there was possibility to straighten some of the flare at the bottom of the ribs.
So with the inspiration-expiration films, the pneumographs, the cinefluorography, and the Röntgen chimograph, and the vital capacity, otherwise, which is a part of what's called spirometry, all showed the same results. Each test confirmed each of the others and demonstrated beyond a shadow of a doubt that the severely damaged lungs of the emphysema patient can, in fact, exhale the air that the medical profession has been thoroughly convinced was stuck in the lungs, blocked in the lungs, and that the muscles of breathing, all of the muscles of breathing, from those high in the throat, the shoulders, the ribs, the diaphragm, and the abdomen, all can be resynchronized so that the patient can breathe, firstly with much less oxygen cost,
The diaphragm contracts and
the
expands
act of
the
breathing, fighting against obstruction, or fighting against
chest
its
cavity
own
larger.
discoordination and asynchrony is very costly in terms of oxygen use. But quiet breathing that Carl establishes is much less costly, much more efficient.
Now, of course, the voice was the important thing all the way through. The whole way to redevelop the diaphragm was for the diaphragm to be able to produce enough pressure to make sound without tensing. This was actually what developed the diaphragm. But no one much paid attention to voice, other than my own ear. But here we started getting voices that totally changed as the diaphragm developed.
And we also did the cinefluorography, which was taking movies of a fluoroscopic screen And we showed the movement of the diaphragm and the movement of the ribs, and then projected these on a screen and took tracings of them, and were able to show the synchronization of the lungs and the diaphragm. And that is particularly dramatic because it's very easy for one to see.
These films, owned by the Stow Institute, are the only cinefluorography films of the human diaphragm that exist in medical history. They document how the respiratory system is designed.
What you are seeing here is two x-rays. The one on the right is the inhale. You can see the lungs are full of air, and the diaphragm, which is the line at the bottom, that is the top of the diaphragm, is sitting very low.
More dark,
On the
more
left,
air.
you are seeing the x-ray with the diaphragm now on the exhale stage and rising very high, pushing the air out of the lung. What you saw just a minute ago on the bottom, from the front, the maximum inhale, and on the left, the maximum exhale. The two x-rays at the top are very rarely done, again, because the one on the right is again the maximum inhale, and the one on the left, the maximum exhale. Now, what is fascinating here is the difference in the width of the body. When the lungs are full of air, you can see very clearly how it changes the entire shape of the body. And people don't realize how large the lungs are. They think the lungs are right in the front of them, right at the chest. But you see, there's actually more lung tissue at the back than in the front. So here you have maximum excursion of the diaphragm. This is over 12 centimeters of motion. Normal is usually considered around 8, and most people on the street are lucky if they have more than 3. But this is maximum diaphragmatic motion that you're seeing. What you are seeing here has never before been seen. You are actually seeing inside a person's body and seeing the diaphragm rise, which it has done now. In fact, it's off the top of the screen. There it is reflected into the inhale, and now it's rising on the exhale. This again is maximum excursion. This is like the x-rays that you saw previously of over 12 centimeters of motion. The lines that you're seeing crisscrossing are the ribs in the front and the back. There the diaphragm again goes into the inhale, and as you can see, it takes longer for the exhale than the inhale. Now this is relaxed normal breathing for a person whose diaphragm is this strong to have this kind of motion. We'll have the same thing now on the left side. Again, you can see the heart beating, and they move the camera to show you how far that excursion goes. Now, diaphragm is risen,
See the heart?
and we will wait now. There's the next inhale. They move the camera, and you can see how far the diaphragm has descended on the inhale. The motion of the diaphragm is totally the result of its strength. If the diaphragm is weak, as we'll see later, there's very little motion, but this is maximum motion. Now we have an emphysema patient with minimum diaphragmatic motion, and as you can see, the diaphragm is not even clearly defined now. In fact, part of the diaphragm on the side is going down, while part near the center is going up. That is called paradoxical motion. And the diaphragm is very diffused. It's not clearly outlined. That is because